I'm Sean Alcorn from the School of Pharmacy and Pharmacology. I'm an early career academic, been with the university for about 2.5 years. Come across from a clinical background in hospital pharmacy and community pharmacy. One of the things I found is that students looked at clinical cases and patients as very black and white, and didn't have the ability to do a lot of the detective skills of finding information and interpreting. Also found they didn't have very strong clinical judgments. So if it wasn't clear cut, they had difficulty dealing in grey areas and picking up that pharmacy and health and medicine, a lot of it is best guesses and trial and error and testing to see if they find the answers. One of the first things I did was look at redesigning the way that we presented our case documents in pharmacotherapeutic education. The way we presented it was very much about student learning, looking at how you identify problems and getting them to identify problems in sort of black and white ways. Is the medication appropriate? Is it safe? It's really, really good, the approach the school has in that learning in teaching students how to find problems. Probably not as good in getting them graduate ready for how to present problems and how to make clinical judgments. So the first thing I did is tried to move across to a more efficient report. But then what I found again, they were still conditioned to that very flat way of learning, and I think it was the way we presented our case studies. And our case studies had single A4 sheets where problems were revealed. If a patient had urinary retention, it said they had urinary retention. If a medication was newly initiated, it said it was newly initiated. We needed to get graduates ready for clinical environments, and we really needed to present them clinical documents and get them to develop detective skills of finding those answers. So I went about developing a clinical environment, looking at developing skills in picking apart doctors' referral letters, or picking apart admission notes, or looking at things like blood pressure rather than our traditional cases said the patient's blood pressure was 130/90, for example, and plotting observation charts from hospitals where students had to pick up trends and remove outliers to try and develop a little bit more depth in the way they thought. Even real simple things of getting students used to acronyms that are commonly used, whether they're approved or not, is something we need to do, and the best way to do that is to fire lots of clinical documents at them. The cases we've used most of the time are they're fictional, but they might be merged across multiple presentations and build extra depth for the purpose of learning, but they're probably based originally on real life scenarios that the academics in the school have come across over the years and blended together. What I get from it is that there's two very, I guess, different cohorts of students. Because they've been traditionally, I guess, used to these flat case sites that tell them exactly what's going on with the patient. Some of the students want to find out straight away. They want it to be very black and white, and I guess that's feeding the problem that we found, is that they look at patients and they look at therapeutics as a black and white issue. The others in the group are very engaged because they're very engaged in being pharmacists, and they love the detective work of being a pharmacist and trying to find the problem. What I think I've found from anecdotal reports from students is even the guys that aren't particularly engaged and want to have stuff straight up know it's a skill that they need to develop. They know it's important, but they perhaps compartmentalise what they need to do for learning and gaining marks away from what they need to do to develop as professionals, and perhaps that they sit that there. So I think they all appreciate the skill set, and the level of engagement depends on how passionate they are about being pharmacists. So we've got work to do to try and build that earlier in our programs so we can push them further and perhaps graduate our students at a level in advance of where we traditionally graduate them, and then we develop them earlier as professionals to be more confident in their opinions, develop the skill set of finding information and how to interpret particularly multidisciplinary reports and that holistic care that we see in most of our clinical environments these days. The lessons I've learned is to do things stepwise. Allow students to culturally change. I didn't force it, so I didn't holistically drop our traditional methods. I introduced the case site that we used as a study resource tool, allowing students to see our cases in the traditional format so we're used to, and then moving across. I think that allows us to work on the culture and move them culturally to be ready for this earlier. So I advise people to, don't make great changes, do things incrementally. The other thing I think is develop your own skills in these areas in ICT, because money is limited and we work in a limited environment. It's difficult to get money. It's also prudent that we spend that money in the right ways. So what I did is I picked up a very small piece of software and I thought I'll model what I want a case to look like in these environments and see then if I can go for some grants to get that. And I started building it, and during that time I built my own skills. And once I got into it, I found I just kept developing this format to try and develop something that I could put to someone, and the next thing I had what I wanted. So I think it's important that academics are passionate about what they do. I think if you want to do something, sometimes it's easier to do it yourself, at least so that you can create a pilot. So I think all academics should engage with developing their ICT skills.